more weeks of summer, so hopefully the weather will agree with us. So welcome to our Medical and Professional Affairs Information Technology Committee. And if I can, I'd like to start our meeting by asking for our minutes to be approved from our last meeting, July 16, 2025.
So moved.
Thank you. So minutes are approved. And we do have a very busy agenda today, so we'll get started right away with our presentation. Ms. Litvinskaya with our first. We're going to bundle the two together, but we will vote separately on these two resolutions. So.
Okay, good morning, everybody. We're bringing forth two contracts that are very similar. That's why we're bundling them together. Would you like me to read it? Urology services at New York City Health and Hospital, South Brooklyn Health, for a contract amount of $19,954,000 with a 20% contingency of $3,990,800 to bring the total cost not to exceed of $23,944,800 for an initial term of 3 years with 2 one-year options to extend. The second resolution authorizing New York City Health and Hospitals Corporation to execute a clinical services contract with City Orthopedics PLLC, the provider group, to provide orthopedic services at New York City Health and Hospitals South Brooklyn for a contract amount of $18,700,000 with a 20% contingency of $3,740,000 to bring the total cost not to exceed of $22,440,000 with an initial term of 3 years with 2 one-year options to extend. So a little bit of a background. We can go to the next slide. Urology and orthopedic services are currently offered at South Brooklyn Health through a subcontract that was held by PAGNI. These are pass-through contracts where SBH is responsible for the entire cost of the contract and indemnifies the providers for the services that they provide at our location and at H&H. In addition to the base contract fee, PAGNI was charging a 3% administration fee for holding the subcontract. They also collected the Part B, the professional billing revenue for the services. The existing subcontracts for both urology and orthopedics are currently expired. They do not have built-in quality KPIs, and they currently have a very limited impact on the PAGNI FPP. PAGNI is aware of our intent to shift the contracts to H&H, and there has been no pushback to the transition. At the bottom of the slide, you would see the total annual cost of the contracts where they stood prior to expiration. Next slide, please. By shifting these contracts to H&H, we gain several advantages. One is that we are going to retain the professional billing revenue that's associated with these services. We'll also have an enhanced control over the service provision, including built-in quality KPIs and performance management. We will eliminate an administrative fee without any additional burden because we're already holding the burden. There's no additional regulatory or malpractice risk because, again, we already indemnify all of these providers. And we will make sure that we have consistency. Most of these providers are our existing providers, and they're all providers in good standing with Health and Hospitals and with South Brooklyn Health. We also are actually expanding services as SBH has continued to grow and expand. There has been more demand for these services. So with the new contracts, we will get additional OR and clinic days. and the cost that's associated with that expansion of service will be covered by the net additional revenue generated by the services provided. Next slide, please. Here you have the contract terms. This would be a direct system contract. It would include quality KPIs with an incentive for meeting them, and a standard 5-year 3+1+1 term. The contract cost includes not just the physicians, but also a full complement of physician associates needed to run the service. These are effectively 24/7 services for SBH. And you see the numbers on the bottom with the not to exceed of 22,440,000 for orthopedics and 23,944,800 for urology. Happy to answer any questions.
Dr. Spiritu, any questions, comments? Dr. Pagan?
Nothing, just sounds like it's great. It's going to be great for our patients. Thanks.
Dr. Katz, any?
No, just to remind people, and it'll come up the full board, PAGNI was created to support us. That's why it's a nonprofit. Most physician groups are for-profit, but it was created specifically to help us. And if we need them, and we need them to do a contract, they will do a contract. And if we find that it's better to do a contract on our own, we do a contract on our own. There's no, this is not a negative on PAGNI. We appreciate that they actually did the contract when we needed them to do it. They do other contracts with us, but when we're able to do it directly, it makes more sense it's not really sensible to contract, which is what it means for them to hold the contract.
That makes tremendous sense. And the actual shares of the departments will be within that contract? Is that how it works?
The chiefs of services
Chief of
will be
services,
part of
exactly.
the contract, and they will report to our chair of surgery, who is an H&H employee.
Yeah, and I think, again, the contact is going to be so much more direct. I don't see any disadvantages. So, no further questions. Dr. Katz, how do you feel?
Yep, all good.
Dr. Spiritu, Mr. Pagan, and I
Yes.
am as well. Unanimous approval.
Thank you very much.
Congratulations, and good luck. All right. All right, our next presentation is going to be Ms. Ford, and you would read it into the record? and
I
then-
will. Authorizing New York City Health and Hospitals Corporation to execute contracts with BioReference Health LLC Laboratory Holdings of America and Quest Diagnostics for referred pathology laboratory testing at a not-to-exceed amount of $38,650,651 for a contract term of 5 years and 2 additional 1-year renewal options exercisable at the discretion of the system. I'd like to introduce Mr. Juan Lugo, AVP of Laboratory Operations, to provide the background and overview. Juan.
Good morning, everyone. Yes, so New York City Health and Hospitals currently refers specimens to multiple outside labs for technical preparation and for oncology pathology related testing when these services are not performing in-house. For the technical work, that may include immunohistochemistry, special stains, and immunofluorescence. Our primary referred pathology lab since 2013 has been BioReference for these services. And then for the oncology pathology related testing, which may include tumor genomics, molecular PCR, next generation sequencing, chromosome analysis, we've been using a pool of vendors for these specialized services. Normally we send out to our joint venture lab, CLNY, but right now they don't offer these services, and we don't know when that's going to be available to us or anybody in the future. Next slide, please. Oh, yeah, that's a slide. All right. So we've assessed our pathology services, and we've identified some key opportunities to enhance efficiency, regulatory compliance, and financial performance. And we've identified the following optimizations. The first one that we aim with this RFP is develop standardized interfaces that will streamline smoother workflows and ensure seamless integration. Second, we aim to create an enterprise-wide strategy for the optimal use of reference labs to maximize value and efficiency. Third, We're aiming to minimize referrals to non-contracted labs to avoid surprise billing and ensure all tests are conducted with New York State Department of Health approval, meaning that any lab that gets our specimens, they have to have a New York State DOH permit. We aim to improve lab selection decisions by contracting with labs in close proximity to deliver timely specimens, which is good for turnaround time and avoid degradation of the specimen's integrity. And last but not least, we're aiming to create a billing and orders tracking vendor interface that will create visibility across system facilities and allow for utilization trends to be identified and shared to clinical teams for action as applicable. So as mentioned in previous slides, BioReference has been our primary referred pathology lab. There was a best interest renewal with BioReference, which was approved by the board in June of 2020 with an NT of $25 million. The contract expiration for that was June 30 of this year. And so there was a deviation memo signed effective July 1st, 2025, expiring June of next year, which increased the NTE value to $29.8 million. The total current spend with BioReference is $29.8 million, of which $10.5 million is attributed to Correctional Health Services, CHS. This excludes any emergency or pandemic expenses. And to note, please, that CHS will not be included in this new contract as their services that they are receiving from BioReference are completely scoped to refer pathology lab. They are getting general lab services. And also would like to clarify that the increased NTE value for this new procurement is due to the aggregation of all spend associated with the scope of work covered by this RFP across all vendors. The NTE mentioned in this slide is just for the BioReference technical services. We've expanded the scopes to include oncology pathology related testing. Next slide. So right here, yeah, we see the criteria that we use to evaluate our vendors. You see the minimum criteria, substantive criteria, and the evaluation committee, which was composed of senior leadership from clinical pathology, lab IT, revenue cycle, and clinical lab operations. Next slide, please. So just to give you an overview of this procurement, we presented this RFP to the CRC in April of last year, and it was approved. We published it in January of this year, sent directly to 25 vendors. We received 3 proposals March of this year. And in May, the evaluation committee submitted their final scores, awarding the technical preparation scope to BioReference. And the oncology pathology related testing scope was awarded to BioReference, Laboratory Holdings of America, and Quest Diagnostics. Next slide, please. So this is the vendor performance for BioReference. They've been performing well, adequate performance, and we're happy with them. We've heard good feedback from the pathologists. So, next, please. And it's the same for the next slide. That's for Quest. And the next slide, please. For Laboratory Holdings of America, they've been performing an adequate performance. Yeah. This is the vendor diversity slide. The diversity team recommended a 5% diverse vendor component percentage for this solicitation on implementation and courier services. BioReference exceeded the goal at 8%. Laboratory Holdings of America and Quest submitted a waiver because they are subcontracting for these services. They believe that they meet our requirements, but they are not MBWE certified in New York State. Next slide, please. So I'll take any questions. Thank you.
Thank you. One question I have is related to, again, there are several different, potential providers here. You mentioned that we're going to try to make sure we do it strategically. Are there certain providers here that are actually doing special tests, and most of them are going to that provider, or is it more geographic that proximity becomes the issue? So how is that broken down, and how's the decision made as to which of the labs to send to?
Right. So our pathology labs have been sending out specimens to their labs that they think are best for them right now. Some of them to close proximity, some of them are far, Johns Hopkins maybe, But with this RFP, what we're trying to do is standardize those services, right? So if you're going to send for a tumor genomics test, we want you to send it to Quest, right? And that's or LabCorp. We have to make that decision, right? Depending on pricing, right, and proximity too. So the reason why we selected those three vendors is because they offer the widest menu and they can meet every scope of service that we have, especially the interfaces, which are really good for turnaround times on getting results back to us and for billing purposes.
Excellent. And that's the other issue, I guess, was related to this comes out looking like a cost center. And as you said, that once this interface is in place, will we be able to then get some sense of what the revenue is coming in from these? So we'll have a better.
That's right. That's the best way to manage the utilization from every hospital lab. Yes.
Great. Other questions, Dr. Spiritu?
That interface doesn't exist yet? Or
It does not exist yet.
and when do you expect that to be created?
I cannot give it a specific timeline, but hopefully within the next year. Yes.
It is prioritized as soon as this is the approval to proceed. It is a prioritized IT activity so that the resources are being put towards this initiative so that we can raise the interfaces as quickly as possible, as well as educate the physicians. Again, we're taking non-standard work that's been on paper and driving it. While we speak of the interface is the pathway in order to bring in utilization, billing, and decision support on the tests that we want the providers to use in a standard way across the system.
I find that the most frustrating thing about labs that are sent out is that you never know when they're coming back. They're just pending, and then all of a sudden it's there.
It is, and to further elaborate, it's not a good use of our resources. We don't want to spend time pushing paper. So this is a win for everyone.
It'd be great to hear some of the results of how this is all working at some point in the future, because it does sound as if things are, again, relatively disorganized. So now hopefully we'll be able to
That's right.
capture a lot more data and, more importantly, again, be able to sort out the financial pieces to it too. Dr. Pagan, any question?
No questions, thanks.
One other question I have is, you do mention about the Northwell joint venture that we have. Are we doing any pathology there at this stage? And obviously these are not. And I guess that would be the next question. And then lastly, working with them as well, we're a pretty huge customer for these companies. And I think the question would be about the unit pricing and so on. Have we kind of maxed out on those things? So.
Not maxed out. Really great question, Dr. Calamia. And we are strategically looking at the buckets of tests that make sense to bring in strategically to CLNY. Obviously, we can't boil the ocean. Right now, we're hyper-focused on these tests as well as genetics testing.
Super. And you also mentioned again about utilization and being able, once you have the interface, to get a better sense and some feedback to our docs about how they're utilizing the tests. And they're not inexpensive tests for sure.
Feedback, but feedback in real time, Dr. Calamia. There's nothing more aggravating than getting feedback that's a year old or a quarter, 3 or 4 months old. So with this, we'll be able to do real-time feedback, problem solve as we need to, but directionally, we should have the tools at our fingertips in order to do what we need across the system.
It sounds really great. Dr. Katz, any comments?
I was thinking, especially with our SVP for revenue in the back, Matt, what the likelihood would have been that we would have sent insurance a bill for a pathology test sent to Hopkins. I mean, this is, you just know there was, whatever services we were getting, they were just living on the hospital budget. We weren't billing for those services. We wouldn't have had even a pathway. And this, provides a pathway for getting the test, for getting the results, for knowing how many tests we send, for knowing what tests we send, and ultimately for billing insurance for those tests. So I think it's a great change.
So hopefully some great collaboration ahead, in finance, IT, and to capture some of that.
I'm in favor.
Same. Yes.
as well, so unanimous approval to go to the full board.
Thank you.
Thank you. And you are still our next resolution. It's the PAGNI affiliation.
Hello, nice to see everyone. I'll read the full resolution into
Thank you.
the
Perfect.
record. Authorizing New York City Health and Hospitals Corporation, the system, to execute an affiliation agreement, the affiliation agreement, with Physician Affiliate Group of New York, PC, and New York Dental Affiliates, collectively PAGNI, for the provision of general healthcare and behavioral health services at NYC Health and Hospitals Harlem, NYC Health and Hospitals Jacoby, NYC Health and Hospitals Kings County, NYC Health and Hospitals Lincoln, Metropolitan, North Central Bronx, South Brooklyn Health, and Gotham Health Belvis, Cumberland, East New York, Morrisania, and Renaissance. The affiliation agreement will run through June 30th, 2030, for an amount not to exceed $7,452,731,569, which includes a 10% contingency. Pleasure to be here. Bringing you our largest affiliation contract. As I think the board knows, since 1970, Health and Hospitals has done its physician staffing through strategic affiliation agreements. We have those agreements currently with NYU, Mount Sinai, PAGNI, and those are the main four, sorry. The affiliate agreements are generally organized by facility rather than specialty. And the PAGNI agreement has over 3,300 physicians through these agreements in FY25. And you see on here the facilities that they provide the services at. Next slide. Since 2010, PAGNI has been our provider at these facilities. The agreements are primarily cost-based agreements. They're pass-throughs to provide physician compensation. PAGNI is unique among our affiliates because it's not directly affiliated with a single medical school or another large health system. But PAGNI does have a major role in our teaching effort. The affiliated hospitals have a total of 189 GME programs and over 1,800 trainees. PAGNI also provides services in our correctional health services, and that's a separate contract from this one, so not covered in this presentation. Next slide. So we've had significant growth in patient volumes at our PAGNI facilities. The total, and that has corresponded with the growth in FTEs, but it has exceeded that growth rate. The total number of FTEs across these sites grew by 11%, where our inpatient discharges and outpatient visits grew by 16 and 22% respectively. The total number of patients served at PAGNI facilities is over 1 million at this point. That's about a 30% growth rate over the last 4 years of this contract. So we've been very pleased to see this growth, and our investment in providers and PAGNI to help meet it has risen commensurate. We organize all of our thinking around our affiliation agreements in 3 major domains: our governance and management of them, the financial implications of them, and then clinical services and operations. So I'll take you through some of what the early days of PAGNI looked like, and then the last 4 years and forward. Next slide, please. So I'd say pre-2021, the last time I spoke with the board about a major resolution of our affiliation agreements, there was pretty limited central office oversight of actual hiring at the affiliate level. Central office paid the budget, but it was handled, I'd say, rather opaquely, with real-time vacancy and spending information pretty limited. And facility leadership had kind of relative involvement in the hiring and which specialties they wanted to invest in, but limited visibility into the overall affiliate budget and its impact on their operations. So the last 4 years across all our affiliates, but PAGNI in particular, have been characterized by creating an overarching governance structure to more standardize the way our joint operating committees work at the facilities and the way our central team looks at hiring at the individual physician and department level. And then at the same time, the budget authority for the affiliate has been pushed down to the facility level, so that facilities set an annual workforce plan budget and then have visibility and control over that budget going ahead. Another key accomplishment of the last 4 years is since FY24, PAGNY's had very consistent leadership. The emergency department chair at Harlem is now the CEO of PAGNY, and he's a great partner to us and leader for PAGNY. So going ahead on governance and management, we want to build on that continued success. We're updating, the contracts are rather antiquated, and we have to clarify some of the roles and descriptions of authority and the way approvals process. We are going to push greater accountability for managing sessional spend, subcontract spend, and locum tenens costs, which are more expensive forms of staffing, down to the chair level, and arm them with the data to make the best possible decisions there, and set them up for better cross-facility partnership. And we're going to continue to move towards multi-year budgets across these affiliates, and kind of greater management of these things as revenue-generating activities that focus recruitment as an investment in driving revenue growth and strategic initiatives across health and hospitals. The next slide, we have some of our financial history here. As I said, the budgets were managed centrally and built really on historical spending prior to 2021. So building those more into our business planning, revenue cycle, and other strategic initiatives has been key. And we've really made a lot of progress on this over the last 4 years. So we've transitioned to workforce plan-based budgets, which set out a year ahead all the potential hires and departments that each facility wants to focus on. The budget is built around that. We view these as revenue-generating investments at this point, which is a different orientation for our facilities, and I think a very productive one. A major structural change for PAGNY is their faculty practice plans, which are the separate entities that bill for physician services. We're separate across each facility, and a year or so ago, we merged those together into a single entity, which was a major effort of coordination on their part, and I think a better way to facilitate collaboration and cross-facility partnership. So we're very pleased about that. We've invested in base compensation to boost our recruiting and make ourselves more competitive in the market, and also had significant cost of living adjustments, in part due to our work with Doctors' Council on overall physician compensation. So going forward, we anticipate a slower growth rate over the coming years, but and part of that is to focus on reducing these fragmented provider services, per diems, locum tenens, and things like that, to focus more on strategic recruitment and retention. And then a major change of the contract this time that I'll go into in a bit more detail is aligning the incentives of our faculty practice plans more directly with health and hospitals. This contract has a significant change to incentivize the faculty practice plans to reduce the number of sessionals, locums, and subcontracts that they have, and has the percentage of earnings that health and hospitals carves out grow as the overall FPP and PAGNY spend grows. So we're very pleased with that change, and also pleased to have the faculty practice plans much more aligned with our value-based payment initiatives, to set them up with a per member per month payment and more clear accountability to drive success in those value-based contracts. On the next slide, our clinical services and operations piece, again, the joint effort of centralizing some of the decision-making while partnering more directly with leadership at the facilities. I think we've got better data at the clinical level. We've implemented clinical staffing models in multiple departments to help facilities baseline their workforce plans and hiring. And we've set up clinical time requirements for leadership, how much time we want chief medical officers, chairs, and others to be practicing. And Dr. Chu is working with chairs around the facilities with Dr. Katz on some of those management expectations for chairs and chiefs as well. Going forward, I think continuing to invest in recruitment and make health and hospitals the destination for mission-driven physicians around the country is going to be a major focus of ours. That's a great thing for us to work on. We've got loan repayment programs and other things to attract early professionals, so we're very pleased about that. And then continuing to advance our shared services. So we are a very large system, and finding ways to work together particularly across hard-to-recruit subspecialties, is a major potential strength of ours and a thing we're very focused on. So this is obviously a very large contract. We're a very large system. Our revenue has exceeded the growth and expense on this contract. It's very much tied to that. And we've had to make significant investments to keep up with the market and make ourselves an attractive place to recruit and retain staff. But it is a revenue-generating initiative, and so we're very pleased that the overall revenue growth has grown substantially faster than the spend on this contract. The administrative fee here is close to what a payroll processor would do, and I'd say in the market are significantly less than many other management services organizations that own and operate physician groups. So I think that overhead is a benefit of this contract versus others that we could see in the market. And then, as I said, we anticipate slower growth over this contract period. The significant investments with Doctors' Council and those cost of living adjustments will carry forward here. And then, our strategic investments will continue, but with that focus on shared services, we don't anticipate the same rate of growth over the coming 4 years as we had in the prior. And so that is our PAGNI affiliation. We welcome any questions, and thank you for your support on this very large and important effort for health and hospitals.
Thank you. I know there's yeoman's work in attaining this, the outcome we have here, which is magnificent. And I guess also just building on what Dr. Katz had said, it sounds like we've really progressed enormously from a pass-through bureaucratic entity to more of a partnership with incentives and hopefully ability to grow and again attract top-notch physicians. So I think that's all wonderful. Questions, comments, Dr. Spiritu, any thoughts? Dr. Pagan?
Just happy to see the increased collaboration and coordination. I think it has always been there, but seeing a growth and seeing the comments you made in the presentation on a joint decision making and committees and working with Central, it's just let's see what happens over the next few years.
Dr. Katz?
There's huge progress in PAGNI as an organization. They've made a lot of progress and a lot of positives in our relationship, and it really, makes a huge difference for our medical services.
Yeah, it sounds like the new director, Dr. Chu, having come from inside, sounds like really able to collaborate well. This is a huge improvement. So, Dr. Katz, your vote?
Yes.
Dr. Pagan?
Yes.
Dr. Spiritu, I'm a yes as well. 4 yeses. So
We'll see you at the full board. Thank you so much.
Thank you. Thank you. All right, and now our reports. We have hopefully at least 5 minutes for
Yes.
each of you, so we can get everyone in
I
as
gotcha.
complete as possible. So we'll start with Dr. Mendez. Thank you.
Mr. Mendez here, System CIO. I will submit to the board our report. It has in it an update on our PMO department, which we are happy to say that we have added a pathway for any new projects or initiatives that have AI in it, which is important. You'll see also an update on 2 major health information technology prioritized projects, as well as the quarterly update on Unprint, which is moving in the right direction, which is down. And what we will focus in on today is an update on our risk management and cybersecurity program, which I will turn over to our System Chief Information Security Officer, Shomra Bador.
Thank you, Kim. Hi, everyone. Thank you. So we can just start here. So I just wanted to start off by giving an overview. As you know, the healthcare industry has been impacted with multiple breaches throughout the last several years. Change Healthcare being the highlight last year. So because of that, it's very important from a healthcare perspective that we, as a system, protect all of the devices that are connected, within our networks. If we can go to the next slide. So essentially, how do we go ahead and protect ourselves from a cybersecurity incident? Not necessarily prevent, but to understand how we can make sure that we have the proper controls in place. So That basically encompasses including all of New York City Health and Hospitals IT resources. That starts from their workforce IDs, what everyone uses to log into their systems, to all of the data that we have within health and hospitals. That includes patient records, which could be part of an EMR system or any other medical system that's on the network, a CT scanner, things of that nature. So we encompass in terms of our protection and the security controls everything from the user ID all the way to medical devices here at Health and Hospitals. Next slide. So how do we do this? A part of it that's very important is governance and having a proper governance structure. So we, as a system, have established that governance since 2015. It's matured over the years. As a part of that, we had in 2015 we established the Information Security Policy Steering Committee, which includes the Office of Legal Affairs, Office of Corporate Compliance, EITS leadership, and HR. So they basically look at the entire governance documents that security brings forth from a policy plan perspective, and those get reviewed on an annual basis. So that basically goes into the next slide, if we can go to governance. And the reason we have governance is mainly because we have to follow a proper framework. And that framework that we follow is the NIST cybersecurity framework, which aligns with all regulations, including HIPAA, and the recently actually coming up in October, the New York State DOH cyber regulations, which will be going into effect. So this allows us to reduce our costs, make sure that we don't have duplication along with the regulation. And we also have an update happening with NIST CSF. Currently, we've assessed ourselves against 1.2. We're going to be assessing ourselves against 2.0 in 2025. Basically the end of this year. We'll have that report in the early next year. But that's very critical because it encompasses AI, the use of AI within our hospital system and the need for additional governance. Thank you. So this is the final slide. So what is the NIST cybersecurity framework? It's basically broken down into these pillars: identify, protect, detect, respond, and recover. So just as a few examples, it's all encompassing. So identify is basically your governance documents, your asset management, what I know the whole team has worked on here with Dr. Mendez with our CMDB. That's a critical component. And then we also have, in terms of protection, it's not just the security tools, but it's also security awareness and training that we provide to our workforce on a quarterly basis. And we also have, obviously, detection with our security technologies that we continually use to monitor 24/7 now. Earlier this year, we became a 24/7 house from a security operations center perspective. And then respond and recover is really to understand if we had a cyber incident, how would we handle that? So an example of that would be annual tabletops that we conduct, which is actually happening in a couple of weeks for us, both at a leadership and a technical perspective. So those are some of the aspects that we cover, and I just want to close with the fact that from a health and hospitals perspective, we have met these criteria, and we tend to be above industry standards over the last couple of years. And I believe the NIST 2.0 framework that we're going to be assessed again over will give us an update with the use of AI and everything else that is coming up. Thank you very much. Any questions?
Dr. Spruder, any questions?
Just curious about this, like when an incident happens somewhere else, whether it's healthcare or non-healthcare related, how do you take that information and then use it to learn or say, hey, are we vulnerable to that? Or
Right. So health and hospitals, we're a part of multiple industry groups. So one of them being Health ISAC. It's basically a group from outside of health and hospitals that has other hospital organizations. There's also another group that has multi-industry information that we get. So basically right now, we're hoping with AI that'll help us and we can automate these processes. What we do is we get that information on a daily basis, which is why it's so important to be a 24/7 facility. And we go ahead and we look at indicators of compromise, and we take a look at that and we see if that would impact our system in any way. And we go ahead and manually block those types of malicious events from entering our system. Obviously, you can't block everything, but that's kind of why we have, this whole cybersecurity framework to try to pick up from that, either from the network level or all the way to the endpoint.
Thanks.
Thank you, Dr. Padilla.
With respect to the AI issue, I mean, sophistication now that's changing with phishing and so on. I'm just wondering, are we seeing much more? Because it was the old days, it was like just look at where'd it come from, and
Yes.
is the language seeming to be? I suspect with AI that's become much more sophisticated. I'm just curious, are we seeing that, and is that all part of the?
It's happening across the board, Dr. Calamia. What's basically helping us with AI is also helping the hackers. If there's another way to put it. But essentially, I think automation is the key for our system, and that's the direction we're heading. And I also believe the additional framework that we've been looking at, NIST 2.0, with the additional governance will help with that. But definitely there's been an update with our threat landscape. We constantly have to monitor and make sure we're protected.
Cats, any comments?
No, I was just humorously remembering that there was a period of time with bicycles where the locks kept getting better and the people stealing the bicycles kept getting better. And there was like this escalation with bigger and bigger locks, and they would just get better and better at breaking them. And I feel like that analogy has a certain truth here too, right? Where we're better and better at protecting it, they're better and better at creating it. And it's like an arms race on, which side wins.
Hope we continue to stay a few steps ahead. Your vote?
Yes.
Yes for me as well. So again, 4 yeses. I feel like America's Got Talent or something. I don't know. But anyway, unanimous to the board for final approval. And thank you again. And I'm sorry. Apologies, we didn't need to approve that, but anyway.
It's okay, we approved the report.
Anyway.
We like the report, we approved it.
My apologies. Kendra.
Dr. Kambadi, please. As we continue to provide the board committee frequent updates on the work coming out of clinical services operations, today we will share with you a high-level overview of capacity management, inpatient, and ED flow. High level, and introducing Dr. Kambadi.
Got it. Good morning, everyone. Wanted to take a moment to talk about this work in inpatient flow and capacity management that we're doing. That's exciting. Just to set the stage, right? When we're talking about inpatient flow, we're really talking about how a patient gets from admission to discharge and how we deliver services like imaging, labs, consults along the way. And if we have the right tools, we can do that in the quickest, most efficient, safe manner, hopefully improving the overall care experience for our patients, improving access to inpatient beds for patients boarding down in the ED, and maybe we can also shave off some mean excess bed days and decrease operational costs. If we go back one slide to that lovely picture, despite a lot of amazing work that we've done in partnership with central office and the facilities, a lot of our care teams still feel like patient flow feels like that image on the left. The main line of this project is really about providing tools that serve as like a GPS for helping clinicians as well as administrators navigate, anticipate, and overcome barriers to flow. Next slide, please. Over the last several years, we've done a number of excellent strands of work in developing our internal EHR Epic for routine discharge planning and managing flow. Some of that stuff includes allowing our physicians and clinicians to manually catalog things like when a patient's going to be discharged and where they're going. But there remains a great area of opportunity for intelligent solutions for clinicians in terms of providing them insights for predicting and being accurate with these expected discharge dates or expected dispositions and services, as well as for administrators for predicting barriers to discharge, as well as for helping them prioritize services from the aspect of the greatest impact that they can have on operational burden. Next slide, please. So as of recent AI advancements in this space, there are really three domains of function
that AI can provide us support in these aspects of the future of how we deliver on flow and capacity management. One is they can help us boost efficiency and accuracy for routine discharge planning. The next is that they can facilitate us anticipating capacity strain and enacting mitigation protocols to respond to it. And then in the third function, they can really help us translate capacity predictions or forecast our capacity so we can anticipatorily align our resources effectively. Next slide. So at present, our strategy with deploying tools in this space is two-pronged. On the one hand, we've done, like I said, a lot of excellent work within Epic, and that work is rapidly expanding throughout our system, and we're honing that work as well. On the other hand, we're also exploring AI-based solutions that'll integrate and synergize the Epic-based work. And overall, I'm excited about this work because it has three potential benefits of reducing length of stay, ultimately improving the experience and safety of the care we deliver for our patients, but then finally it gives us an alternate lens into how we actually deliver care that we don't currently have if we introduce AI into this realm. So I'm happy to take any questions or feedback.
Questions?
No questions,
right.
thanks.
Thank you so much. Appreciate it. All right. Dr. Sinez?
Thank you so much. Next slide, please. We continue to focus on professional development, looking at our associate degree nurses to enroll in baccalaureate programs, but also our nurses and nurse leaders who would like a DNP or PhD. And so we're partnering with CUNY on that endeavor, and we held a virtual information session on June 18, 2025, where over 140 people attended, which we are really proud of. Next slide, please. We also continue to focus on higher standards of nursing practice. New York City Health and Hospitals Metropolitan is the first healthcare organization worldwide to earn the Pathway to Excellence with distinction, and that essentially means not only is Metropolitan fostering a positive practice environment for our nurses, but they're also exceeding national benchmarks, which we're really proud of. Next slide. This is just another photo of all of us celebrating. In the room are physicians. Every level, every employee you can possibly imagine was in the room. So although it's a nursing designation, it's really a team effort. Next slide. Pathway to Excellence with distinction was also awarded to Carter, the first long-term care facility nationwide to receive this designation. We're really proud of the Carter team. Next slide. You see here frontline staff, the CEO, and many other members of the team as well. Both teams will be recognized on a national stage next month, October, at the Pathway and Magnet Conference. Next slide. Queens also celebrated the PRISM Award. This national award signifies a premier recognition in the specialty of med-surg, and Queens B4 East Unit is the first to receive this designation within New York City Health and Hospitals Health System. We celebrated on July 16th with more than 100 members of the team, majority of them being frontline staff. Really proud of the Queens clinical outcomes. Next slide. Up here is a photo of actually the C-suite at Queens coming together as they embark on the highest possible designation within nursing, the Magnet designation, which we launched July 16th, where we had over 150 hospital leaders all come together to really prepare for this journey. Next slide. The last two programs I would like to talk about are just two programs we have in place here at New York City Health and Hospitals focused on staff retention. Next slide, which is our report of professional governance councils. We have over 211 councils right now, which are led by frontline staff, looking at their clinical outcomes and really making a difference. Next slide. And these are just photos. You can see the excitement in the room, a lot of pom-poms and garb, because the nurses are really excited about making a difference and having a voice and really setting the stage for structural empowerment here at Health and Hospitals. Lastly, our clinical ladder program, which is part of our NYSNA contract, continues to thrive. We've seen over 200% applicants into this program, which is key for professional development and retention of our nurses. So we look forward to recognizing our nurses this month at the Clinical Ladder Program Day, but also as they submit their professional portfolios at the end of the year, supporting them with their evidence-based practice projects. That concludes my report, which is really proud and celebrating all of our sites who are really taking nursing excellence to the next level here at Health and Hospitals. Thank you.
think we're all extraordinarily proud. This is really dramatically over the years been progressing, and we're grateful for that. And obviously, hopefully, we'll see the effect on recruitment, retention, all these programs, because they're just magnificent. So thank you for that report. Lastly, we have, I think Dr. Shah is going to be doing Dr. Schwartz today, so all yours for MetroPlus.
Thank you very much indeed. On behalf of Dr. Schwartz, I'd like to provide this update for MetroPlus, focusing on 4 areas. First and foremost, on quality. We learned last month, there's always a bit of a delay with New York State reports these results, so we just learned our 2023 results for the MetroPlus HIV SNP, and for the 3rd year in a row, we are number 1 in quality amongst the 3 special needs plans that exist in New York State. The award is based on 3 areas. 80% of the award is based on clinical measures, 20% on satisfaction, and then they deduct points based on your lack of compliance to various state initiatives. Very pleased to report that on the quality side, we far exceeded the other 2 SNPs by several percentage points. On the quality side, 45% of the points are derived from viral load suppression, which is, as the board appreciates, the single most important predictor for both individual disease progression as well as community transmission. We scored 45 out of the 45 available points. The remaining 55 points in quality and clinical side are based upon a holistic approach to people living with HIV, including STI screenings, primary care, mental health, substance use, and social needs and screening intervention. And we're pleased to report that then even in those areas, we did very, very well, particularly in the mental health side, where a lot of comorbidities exist in people living with HIV. It's a special focus of our care managers. And I think this underscores for us the importance that people living with HIV and Medicaid should be enrolled in our special needs plan. If they're in the system, it really makes a lot of sense from a care management perspective and a collaboration perspective with providers. Next, want to focus on another special population in Medicaid, the health and recovery plan population. These are people selected by New York State through a state-based algorithm who have severe mental health or substance use issues or both. The state designates these individuals based on utilization as being HARP eligible. And the Quality Incentive Award is based upon withholding 2% of the HARP premium from each of the health and recovery plans. And if they do well in quality parameters, then a proportion of the premium is returned to the plan. We're pleased to report that for the first time, MetroPlus was able to earn the full Quality Incentive Award. 100% of the premium withholds returned back to the plan. And we saw a pretty dramatic improvement in quality outcomes, a 28% increase compared to 2022 in many of the quality parameters. As you can imagine, again, with this population, the majority of the points are derived from mental health and substance use derived measures, but there's also measures that deal with screenings, viral load suppression, asthma medication ratio. And as the next slide will point out, we saw increases in the substance use measures, in the mental health measures, particularly after discharge from an inpatient or ED setting. But we also saw a 30% increase in the use of controller medications for asthma, again, emphasizing the holistic approach to people living in the health and recovery plan. The next area is on Marketing Cloud. The state has encouraged plans to really push innovative ways to ensure people have a good onboarding journey to each plan, as well as ensuring that when they come up for redetermination to make sure they're still eligible for their line of business, that we try and get as many people appropriately recertified. And MetroPlus made a significant investment now more than 3 years ago in Salesforce as our CRM system. We are now using Salesforce Marketing Cloud to personalize outbound messages both on redeterminations as well as on onboarding. And this allows us to ensure that we are able to have a very tailored messaging as well as the ability to look at outcomes as a result of any outbound messaging that we give. It's much more centralized. Previously, there was a lot of different areas doing a lot of outbound recertification work and onboarding work. Now it's all in one Salesforce setup. Next, please. So what we did was we initially did pilots, both for recertification as well as onboarding, where we took people who are getting the current state, and then we used Salesforce Marketing Cloud as an approach, so we could compare our current state with which will hopefully be the future state. And the pilot was both in redetermining people in the essential plan and Medicaid, and then the onboarding was for people in Medicaid. And so there were 30,000 members in the control group, about 3,000 in the Salesforce marketing pilot for recertification. And we noticed that the individuals in the Salesforce arm had nearly 3% higher redetermination. That was statistically significant. And now that approach is in full-scale production across all lines of business where redetermination is required. Onboarding, we again did a comparison, current state, which is more decentralized, to a more centralized approach with Salesforce Marketing Cloud. We did see a higher retention, meaning and more engagement with primary care visits as they onboard members. One thing we didn't see, and we want to see an improvement on, is more portal registration to Salesforce. We're hoping that with ongoing messaging, that will also increase. But with the improvements in retention, lower call rates to the call center as a result of the messaging through Salesforce Marketing Cloud, as well as hopefully more portal registration. We've put this now into full-scale production. One of the big benefits of all of this is that now all the messaging can be seen and visualized in one central CRM system. So when a member calls about a message they received, the call center can see, oh yes, you received a message 3 days ago. I can see what you received, a question, and then they can follow up without having to ask, for the member to read out the message that they received. We must improve our provider directories. It's imperative. The state has a huge scrutiny on ghost providers and providers who, when they're listed in the directory, when the state calls, they're not able to access them. That reflects poorly on the plan. So we've partnered with Better Doctors, a vendor, to create a mechanism to send out information on demographic information, have the plans, the providers return that information back to us, both in the primary care realm, specialists, labs, freestanding radiology, behavioral health. All of these sectors need improved addresses, hours of operation, ability to see new patients, as well as accurate telephone numbers. To date, over 41,000 data updates have been made as a result of that. Next slide. And then we're also doing our own access and availability surveys based on state requirements. And providers who do well in these surveys can earn per member per month additional fees for meeting target compliance rates. And we're also doing secret shopper calls in the medical, behavioral, dental spaces in order to ensure that discrepancies are identified and rectified as much as possible in real time. And lastly, just to talk about MetroPlus Gold, this is a plan that MetroPlus offers exclusively for city employees. For July 1, we have enhanced our benefits with a huge focus on wellness. You can see there on the screen, we have reimbursed for ClassPass, which allows people to access various gyms across the city. We cover gym membership up to $1,400. We introduce acupuncture as free acupuncture visits for up to 10 a year. People are going to earn wellness rewards for attesting to primary care specialty care appointments, dental access. And then we have a gold no rider where you don't have to purchase a pharmacy rider, but still over 100 medications are available free of charge. And for the rider, we've able to reduce the rider fee by $11. So we hope this is an attractive for city employees to consider. Happy to take any questions.
We are at the end of the hour, but if there are any questions at all? I guess the only question I would have is, at what point are we expecting impact from the changes in Medicaid? Have we sort of prepared for that, and are we seeing any issues yet?
So I think the Medicaid impact will come a little later, Dr. Calamia, but I think the biggest impact we're now foreseeing is in the essential plan. I think we hope that the governor creates a funding stream for the essential plans to continue, but that's the area to watch for first.
Great, thank you. Any other questions, comments? Otherwise, thank you all. Appreciate it. Meeting is ended.
Perfect timing, too.
Wow.
10:02. Close enough. Close enough for government work.